Welcome to the first Vodcast from BURST, filmed at BOUST 2024, kindly funded by Astellas. Hello and welcome to the first ever BURST Vodcast. We're going to talk all things OAB, and this podcast is very kindly supported by Astellas. We're going to use the funds for BURST research activities, and we have a brilliant panel here of urology clinicians with us today. I'm going to let the panel introduce themselves, so starting with Nick.
Thank you, Nikita. So I'm Nick Boxall. I'm a consultant urologist based in Sheffield. I subspecialise in spinal injuries and neurourology, as well as wider functional urology as well.
I'm Sophia Cashman. I'm a consultant in Nottingham, and I specialise in female reconstructive urology.
My name's Eabhann O'Connor. I'm a consultant urologist in Dublin, in Ireland. I specialise in reconstructive urology, and I'm just finishing a fellowship in male reconstruction and urethroplasty as well.
And I'm Sarah Hillery, Advanced Nurse Practitioner in Urology at York and Scarborough Trust. I'm also President of Eabhann. Continence is one of my key clinical specialties, and OAB is one of those subsets of patients that I see within that specialty.
Brilliant. Thank you everyone for joining us. I really appreciate your time. So what we're going to do is go through a typical OAB case today, hopefully someone that you see in clinic quite often, and go through their sort of initial presentation, assessment and management. So there's a 43-year-old lady that's presenting to clinic with what the GP letter says is overactive bladder. The GP mentions that she's tried a few medications in the community that haven't really worked. She's had 2 vaginal deliveries and is otherwise well fit lady. So she's seeing you in clinic for the first time. So Nick, starting with you, what would you say is a typical presentation of an OAB patient in clinic, and how would you elucidate the history, and what kind of symptoms would you expect from this patient?
So, excuse me. So it's fairly bread and butter presentation. So the majority of my new referrals are sort of this is sort of the classic presentation. The typical symptoms would predominantly be the storage lower urinary tract symptoms, so frequency, urgency, nocturia. Want to get an idea of how bad those symptoms are, how they're affecting their quality of life, and then their past medical history as well. Obviously you've given some obstetric history as well, so I want to dive into that and the wider gynecological history. You mentioned about some medications which they've tried and have failed, so I want to get an idea as to what medications, how long they've been taking them, what dose, have they been taking them for long enough, those sorts of things. And it'd be interested to know as well from their wider medical history. So I mentioned obstetric, but also any other neurological symptoms. So certainly I see a lot of patients with neurourological problems such as multiple sclerosis. So I want to make sure there's no red flags, and then also ask about other symptoms associated with things. So are they getting recurrent urinary tract infections? Is there any evidence of any visible hematuria and things like that to make sure that they're not missing out on anything that could be anything sinister to account for that. And then in terms of the initial sort of workup, so before seeing them, once I've seen that referral, ideally these patients would be seen in a one-stop clinic environment. And before actually seeing the patient, it'd be nice for them to have a bladder diary or a frequency volume chart that they completed prior to coming to clinic, have a post-void residual on arrival, and also a urinalysis as well, and then take things from there.
Great, thanks Nick. That was quite detailed. I'm sure anyone doing the exam would benefit from that answer.
It felt a lot like I was in the exam.
Yeah. We practiced together, so yeah, it sounded like our exam answer for sure. So she has urgency, nocturia, urgent incontinence, no stress incontinence. She wears 3 pads a day, and has tried oxybutynin, to answer the question about the medication. So Sarah, can I ask you, when you see these patients in clinic yourself, do you find that there's some sort of taboo associated with presenting with OAB? do these patients struggle to present? Do they come to you quite late? From a patient perspective, what are the challenges that patients face coming into a clinic to see someone like us?
Undoubtedly, patients can wait years before presenting to their GP. And even then, once they've gone to the GP, it can be a number of years before they're referred to us in secondary care. Particularly because, as you identify, there's a lot of shame, there's a lot of personal impact, relationship, work impact of conditions like overactive bladder. And also within that, there can be problems with the patient's bowel. They may also have problems with IBS. Perhaps in addition to Nick's assessment, I might have included a bowel assessment to look for constipation, and then perhaps a surgical assessment as well, because if this is a woman who's had a hysterectomy in the past and been de-estrogenised for many, many years, perhaps there's an impact there. So when I speak to women in clinic as a new patient, I really take time to listen to the woman about her own experience, the things that are important to her, and the things that have really impacted her with her overactive bladder symptoms.
Yeah, absolutely. So she is really, really bothered by this problem, and because the medication gave her side effects and didn't really work, she is now quite desperate to try something. In terms of sort of trying to get a further history of risk factors, Eabhann, coming to you, what kind of risk factors would you be looking at that Nick's really good history haven't already covered?
I think Nick and Sarah have really covered, the majority. I think comorbidities are very important to exclude. Diabetes is becoming more and more prevalent, and it's always, I think, helpful to rule that out as well. Their fluid intake, and reviewing the bladder diary in terms of their caffeine consumption and their overall fluid intake, particularly if the likes of oxybutynin has been tried, it can often, the dry mouth can precipitate more and more drinking. So I think patient education is very important in that sense, and actually where I work, the nurses and physios have made some educational videos just on bladder and bowel management, and when a referral is received, we direct them to that before they're seen, so that at least lifestyle modifications like fluid modification, smoking status as well as important, estrogen status as you had alluded to, could all be assessed prior to then being seen in clinic, or for patients to be aware that they are potential contributing factors.
Yeah, like a lot of these referrals come through from the GP and no one has taken a fluid history.
Yeah.
So like we expected, this patient is a big coffee drinker. She drinks about 5 mugs a day.
Right.
Drinks very little water. She's not a non-smoker. So let's say she hasn't tried any of the sort of lifestyle changes. I think we see this all the time. So Sophia, in your practice, what would you do at this point? Someone who's not done the conservative measures, has tried one medication, is desperate. So in my experience, when you start from zero now, it's quite difficult to convince the patient to go back to conservative. So how do you deal with that?
So I think I'm very lucky we've got an excellent continence advisory service. So in my practice, a lot of people have the basics. So usually they will have had a bladder diary of some form, a good talk about sensible fluids, not forgetting things like fizzy drinks as well, which are really irritating. And drinking late in the evening if they're getting up and irritated by that. And I do think that when you talk, especially if they've had a bad side effect from medication, if you take it back a bit and say, actually, some lifestyle changes may be sufficient for you, they're usually willing to give it a go. I think being fair, if they've had a really good trial of very sensible fluids, and a lot of them have gone to, just water for a while, and it hasn't changed their symptoms, there's no point reinventing the wheel about that. I'd certainly hope someone's examined them at some stage, and again, our continence advisory will do that, assess the pelvic floor, make sure they've got some good tone. I'd want to make sure that someone's checked they're emptying their bladder, and a simple post void will do that. Again, that can be done in the community. And I'd hope they'd have a urine dipstick. It's helpful for many things, but making sure they haven't got blood in the urine, for example. I would then, if I was seeing them, I would talk to them about other medications to start with. So I'd see what in my experience, oxybutynin orally is poorly tolerated. The transdermal's better, but I never have much. It's not something I prescribe myself. So I'd have a sensible chat about the alternatives. So that would be other anticholinergics or something like mirabegron. and talk to them about the pros and cons. I think we used to have a kind of adage of you have to have failed a number of anticholinergics, but now with all of the info on the cholinergic burden coming in, AUA have changed their guidelines recently, so I kind of offer both at this stage, especially if they've had bad side effects from anticholinergics. It's very difficult to convince them that trying another one's the right thing. Although anecdotally some people do just get on better with one than the other. I find solifenicin's very well tolerated, as is tolterodine generally. Sometimes trospium's better in the elderly population with the theory that it doesn't cross the blood-brain barrier. The other thing we haven't touched on is the post or perimenopausal state that you can pick up genital urinary symptoms of menopause, and I actually use Vagifen pessaries, others are available quite early on.
Oh, definitely,
I find it really helps with irritative symptoms.
I find women are delighted when I prescribe that, and they leave the clinic. They feel like you've done something to really change things in that moment,
and the benefits can be, felt quite quickly. Actually, which is.
So Nick, coming to you, Sophia already mentioned about anticholinergic burden, but for any trainees watching this who are coming up to the exam, can you tell us more about what are the concerns with anticholinergic and what kind of populations would you be more concerned about? And in terms of mirabegron, is there anything else that you are sort of wary of while prescribing that?
Yeah, absolutely. So with I think, first of all, with anticholinergics or antimuscarinics, however you want to refer them to, I think you always have to be, patients need to be counselled about sort of all of the issues. So the anticholinergic burden is sort of very specific to sort of more the neurological side of things, but say, obviously, we would want to mention about problems such as dry eyes, dry mouth, constipation, and again, that can have an impact on their fluid intake, as we've already mentioned. There is sort of a growing body of evidence about the effect that it has on cognitive ability. So certainly would be concerned about prescribing them in sort of the elderly population. Again, say some are thought not to cross the blood-brain barrier due to the molecular size of it. So as I think Sophia mentioned about trospium is one option, but again, it'd be something to be very cautious about. And so that's sort of the side of the cholinergic burden. With and I say, as Sophia mentioned, I think I have a very similar opinion on this. Is that I will, if a patient's not tried either or any medications, I will counsel them about anticholinergics and mirabegron at the same time. Mirabegron is, say, if I'm prescribing that, would sort of one of the concerns is about uncontrolled hypertension, and so if it's controlled, that's fine, but it's a very easy thing to do to get a baseline blood pressure reading in clinic.
So this lady is obviously 43 and quite fit. Sorry, and we've talked about medication. She's tried the mirabegron. She refused the anticholinergic after her experience previously, but now she's back into your clinic miraculously in 3 months. We actually never see them. However, she says the mirabegron didn't work. So with regards to assessment, you gave us an excellent overview earlier. Could you tell us, at this point, we'd call her failed medical management, what would you do next, and how would your assessment change from here?
So we're now really getting into the realms of more invasive management strategies. So that would be Botox, sacral neuromodulation, and then you've got the bigger options of things like augmentation, cystoplasty and diversions. But we tend to reserve that for really quite extreme cases. It's big operations with a lot of risks long term. In our practice, we would tend to discuss these cases at an MDT prior to going into any of these invasive choices. Botox for an idiopathic overactive bladder, we would start at 100 units. We tend to do the majority of these under local anaesthetic. It's generally very well tolerated. And things like we used to stop all anticoag before, but we don't necessarily do that now. We give them the option, but tend to just carry on. And then we would see them with a post-void residual in 2 weeks, an hour at nurse-led clinic, and then we'd follow them up in 3 months. The majority of patients we will teach ISC prior to Botox, We know it's about 1 in 10 for women that need ISC, and it just means that for that 10%, if they run into problems at any stage afterwards, they can get themselves out of trouble. It's also very good to know that they can, because when Botox is in, it's in. It lasts various times depending on the individual. Most people get about 6 to 9 months out of it. Some people can get longer, some people it's shorter. And if they can't self-catheterize, and they are in the kind of 1 in 10 area that have gone into retention, the option's an indwelling catheter for the entire time. Most people would want to know that, and I think we're very much obliged to explain this, because if they are the kind of person that says, my worst case scenario in life would be a catheter, you really need to have quite a nuanced discussion as to whether or not that's the right thing for them.
Yeah, and I think it's also about, we were talking about urodynamics prior to invasive management, and I don't offer to all, I don't, I suppose, require urodynamics before Botox in all idiopaths, but I think it is about identifying those potential patients who are actually the true or underactivity patients, those older patients, maybe a higher initial PVR. Those are patients I would definitely get urodynamics on, because I agree, I think those are the ones that you feel may run into more difficulty after the Botox. And one other thing to mention that I've started to utilise more in conjunction with our physios is transcutaneous tibial nerve stimulation, and that's something, I suppose, relatively non-invasive that patients can use at home. So I've patients now buying TENS machines and performing tibial nerve stimulation themselves at home, and actually a lot of patients are reporting quite good outcomes, and the European guidelines are suggesting as well that there's really quite limited difference between percutaneous and transcutaneous application of it. So it is something in conjunction that patients could be offered. I agree.
Yeah, absolutely. Just to summarize, we've discussed for treatment so far, we've discussed Botox, SNS and PTNS. Eabhann, so I direct the sort of last bit of this session to you. Sophia already mentioned augmentation for these patients. When was the last time you saw one? I know we always say it, but are we doing it, and should we be not offering it? Because I know a couple of my consultants who would say, don't mention it in the first consultation. It's kind of controversial in terms of a lot of people shy away from doing them for idiopathic.
I think it's a really good question. I haven't seen an augmentation cystoplasty in about 6 years, since I was in UCH, and I agree, in the idiopathic cohort, our treatment algorithm has evolved so much from, with Botox, with SNS, from a time when really those weren't options, So obviously it's very different in the neurogenic population, but for idiopathics, I think you really need to be at a very end stage situation, having failed high dose Botox, high dose SNS.
Thanks very much. I think we'll stop there. I'd like to thank all of you for your incredible insights and knowledge on this, and I hope this is useful for anyone doing the exam or otherwise. And we'll tackle OAB in men in the next segment, so don't worry, we haven't forgotten about that.